Yeah, if you just want to just like say, hey, this is important, and then I have my little notebook, I'll
Okay, that's
write
fine.
it on down.
Okay. So on your on the PowerPoint, I have this little cartoon. And it's about delegation and supervision. It's two guys walking together, and it says, I like things to be done my way, but by somebody else. And I think we've all been in that situation, right? We've all been in that situation where somebody tries to tell us what to do, but we have to do it their way or the highway. And really that's not delegation, that's not supervision, that's micromanagement. And so I think it's so important that we understand what delegation and supervision is about. Everybody we work with is a professional. Everybody brings expertise and knowledge and experience to the table. And so we have to work with one another, understanding that. So it would really be dumb of me to delegate a task to somebody and then spend 10 minutes telling them how I want it done when the task would have taken me 5 minutes to do it, right?
To do it. Right.
But we
Sounds like
all
my kids.
know those people who do that, right? Who tell you, this is how I want it done, this is when I want it done. And they give you this detailed complex. And in the meantime, they could have just gotten their ass up off the chair and did it themselves.
Right.
That's not delegation. That's micromanagement. And micromanagement really sets a very poor work environment for everybody to be involved in. And so I think that, I want you guys to take away from this that your job as an LPN is not to micromanage CNAs, not to micromanage assisted personnel or whatever term we want to put on them, but to help lead them, to make them become better at what they're doing, to instill confidence and expertise, and letting them really take the ball and do what they're good at. Just as RNs should do the same for you, just as providers should do the same for RNs. That's the work environment we need to create. And the only way we change the environment is by us doing it. If we become the model, everybody will fall in place. And so it's so important that we do that, okay? So when we talk about delegation, delegation is truly transferring the authority to another member of the healthcare team to complete a task while retaining accountability. So it is still my accountability as the provider to ensure that that patient is taken care of. Ultimately, it is my responsibility as the provider. But I delegate those tasks to nurses and LPNs in nurse aides or, whatever term we want to put on them. Every institution calls them something different. But it's ultimately my authority that starts that chain reaction as a provider. But I can't micromanage that. I can't be there to tell everybody what to do, how to do. That's not my job. My job is to set parameters, to set guidelines, to set expectations. And then I let competent professionals do their job. That's delegation. Okay? You can delegate only tasks appropriate for the skill and education of the nurse who's receiving the assignment. I, as a provider, could not write an order for any of you guys to give blood products. It's not within your scope of practice. I could not ask you to administer the first IV medication. It's not within your scope of practice. Just as I would not ask a nursing assistant to start an IV. Just as I wouldn't ask a nurse to write orders or to intubate or to do something like that. You can only delegate a task that is within somebody's scope of practice or within their skill set. I still wouldn't ask a brand new nursing assistant to go check vitals on somebody who was a cardiac patient. It's just not in their skills.
Mm-hmm.
I'm setting them up to fail. I'm setting the patient up to fail. So it's important that we think about those things when we delegate and when we pass those things on. So very important that we think about those things and that we, you can only delegate what's needed. Important to know, because that is the test questions you're going to get. You will be asked a set of 4 patients. Which patient can you take care of as an LPN? What patient can somebody take care of as a nursing assistant? You'll be asked questions, which patient is most critical? Which patient deserves the first assessment? Those are the things that you need to talk about. Does anybody know the number to call in?
I do. I gotta get it.
Could you, well, if you could tell me it and I will send it to Joe.
Okay. I guess I gotta find it. Sorry.
Okay, no problem. I got way more time than money.
So do I. Okay, so wrong book. Just a second here.
While she's looking for it, I gotta go check the score of my game.
Okay.
I gotta know if my Vikings are losing yet. Oh my goodness, we're ahead.
That's my mom's team
Second
too.
quarter, but things can change.
Just like them Huskers.
Oh, never mind. Reggie got it for him.
Okay.
Okay.
You want it? I'm almost there.
Nope,
You
Reggie
want it?
got it from Reggie. Reggie sent it to him.
Okay.
Okay. So when we're talking about delegation, it's so important that we think about, hey, Reggie, that we think about what can we delegate, who can we delegate it to, and should we delegate it? So important. If you're the senior LPN on the floor, should you delegate the most critical patient?
No.
No, right? Because you're the most senior person to take care of it. You're the most experienced person to take care of it, right? So that's what delegation is asking yourself, can I delegate it? Should I delegate it? And who can I delegate it to? Because there are too many things that we have to get done. We can't do everything. So we need to figure out what can be delegated for. But we have to remember, you delegate it, you still assume authority for that interaction. It's still on you. Okay? So very important that we talk about what we should do. Not very long ago, I've delivered babies before, but is it in my scope of practice? No, it's not in my scope of practice. But in an emergency situation, I do what I got to do for life-saving measures, right? So a couple weeks ago, I had a patient come in and she was, I don't know, he went in and checked her and he thought she was dilated to a 7 and he's like, we're going to have to deliver her. We can't send her down the road. Okay. So I go in and I examine her and I'm like, I'm just going to recheck her. She's at a 2. And, I'm like, but he thought I was going to deliver this baby. I'm like, buddy, I'm not an MD. I'm just an MP. Let's remember the roles of authority and delegation here. So we're always caught in this loop, okay? And so it's so important when you take your tests, you work in a perfect world, right? We work in a perfect world. There's always somebody who's more experienced or higher up the ladder or whatever the case may be to take care of it. So you choose what you should do. But we know in real life situations, that's not always the case. Things are going to happen. We stretch our limits. Now, we have to be very careful about it, but we stretch our limits and we push our scope of practice at times. Have to be careful. But when you're taking the tests, and when you're in real life situations, you live in a perfect world when you take the NCLEX, okay? So when they ask you what task should you or could you delegate, so should you delegate putting a urinary catheter in? No, because you're qualified to do it as an LPN, right? Should you
Right.
delegate starting an IV? No, because you can do it. Can you delegate getting a set of vital signs? Absolutely. You can do that. You can delegate that. So you have to think about, what can I delegate? Who can I delegate it to? And should I delegate it? Okay. And
Yeah.
the goal is, or we always have to work within our scope of practice. Has Bree given you guys an outline of what the scope of practice is for LPNs? She'll probably give that to you right when you go on the floor. As you go on the floor, but things that you can't do as an LPN, you can never administer blood or blood products. You can never give the first dose of IV antibiotics. You can never give anything more than 20 milliequivalents of potassium. You cannot access a central line. You cannot do discharge teaching. You can reinforce teaching, but you can't give it. You can never do the initial assessment on a patient. You can do subsequent follow-up assessments, but the initial assessment has to be done by an RN. That's just some of the things that are not within your scope of practice. Now, remember what we said way back when, scope of practice is different for every state, right? Because it's based upon state law. So when you guys are down in Nebraska, you will never start an IV, because in the state of Nebraska, LPNs cannot do that. In the state of South Dakota, you can. So there's some little caveats in between states and those kinds of things, okay? When things to consider when delegating, what's the predictability of the outcomes? So is this patient a high-risk patient? If this patient's a high-risk patient, should you delegate that patient? Absolutely not. So if there's a code going on, do you think you can just say, hey, I'm going to go for my coffee break now? Not acceptable. You can't do that. What's the potential for harm? If I delegated this, could there be harm to the patient? If there could be, you can't delegate it. You cannot delegate it. The complexity of care. How complex is the care? Do you have to be very careful? So things I would think about if I had to put a suprapubic catheter into somebody, because a suprapubic catheter is really, more of a sterile technique, more so than a urinary catheter. So I would never delegate that. I would do that myself. It's not something everybody does, suprapubic catheters. It's not frequent. Thinking about those complexity of that patient is so important. What's the need for problem solving or innovation? So what happens if something goes wrong or if something goes right?
You're responsible.
Right. And so would you be comfortable delegating that to somebody else? I wouldn't. If there's a chance of something to go wrong and I have to take, and I'm the one who's responsible, I'm not delegating that. I'll do it myself.
Right.
So you have to think about those things. And then what's the level of interaction with a client? And, a lot of times you do things just to put clients at ease. It is the way it is. And that's how you delegate and how you give things up. You need to think about education, training, and experience. So when you're delegating, do they have the training? Do they have the knowledge, the experience to accept that task? Do they have the knowledge and skill to perform the task? Right? So if you need to put a urinary catheter into somebody, you can't give that to, a nursing assistant, right? You can't even give it to a med tech because they're not licensed to do that.
Right.
Level of critical thinking needed to complete the task. What's the ability to communicate to others? Because we've all worked with that patient who's very, very smart, but they can't communicate to other people, right? We've all worked with that person. And it's okay, but I don't want that person delegating tasks to somebody else, because if they can't communicate very well, they probably shouldn't be delegating tasks to somebody else, right?
Right.
It's very important to be able to communicate things. And what's their demonstrated competence? So if I had if I had a little tiny baby come in and I needed to start an IV, I know each and every one of you will be licensed in starting IVs. I wouldn't let you touch it just because I've done it. And I'm going to have one chance to start that IV. And I'm not being critical of anybody's level. I'm just saying I have one chance. And looking in the room, I probably am the one who has the best chance. That's just how it goes. And then looking at what the facility's procedures and policies are. What are those policies regarding delegation? And can they do it? Because even though your state or you might be licensed to do it, in a certain facility, they may have different rules and different policies that limit your scope of practice. And so you have to be cognizant about those kinds of things, okay? As an RN, can I give chemotherapy medications? Absolutely. But would I ever go to Sanford or to a Vera McKinnon and give them? No, because they have specialized chemo nurses to do that. I wouldn't do it. Somebody else would do it. So that's the policy and the procedure for that institution. And then what the licensing legislation is, so what your board of nursing says and those kinds of things, having to follow those kinds of rules. Now, supervision is different than delegation. Supervision is the process of directing, monitoring, and evaluating the performance and task of another member on the healthcare team. Okay, so just because you delegate something, does that mean that you're their supervisor or that you're supervising them? No, right? So you may be the LPN for that day, but that does not mean that you're in that supervisory role for the day, because there may be an RN over you, or there may be, somebody else over you that day, a more experienced LPN, or whatever the case may be. So supervision is a little bit different than delegation. And I think we fail in supervision in the fact that a lot of people like to direct and monitor, and people like to be critical, but people don't always like to give constructive criticism, constructive feedback. And that's the vital component of supervision, right? We've all had those supervisors that were like, whatever, because they don't give us that positive feedback or that constructive criticism. being able to say, you know what, hey, you started that catheter today, really wasn't sterile technique, so let's think about what we could have done differently. Because I've started many catheters on people that were not sterile technique, because I've had inmates come in who are kicking and screaming and spitting and hollering at me. That's not sterile technique. It's a poke and go, buddy. It's a poke and go. So you have to understand that yes, we need to be sterile. Yes, we need to follow policies and procedures and standard of care. Absolutely. But there are times that we can't always do that. And so we need to sit and talk about those things. And we need to have an understanding, an open conversation. I'm not here to critique and to criticize and those kinds of things. I'm here to talk about what could we done to make the situation better. I've worked in several codes that were complete chaos. Complete chaos. Everybody's screaming and hollering and telling everybody what to do. And it's like, this is a stressful enough situation without everybody biting at each other's jugulars. We need to stop it, step back, and focus on what your task is. And so sometimes it's important to be able to step up to the plate and say just that. You know what? Hey, I've got the airway. Can you handle the meds? And at the end of it, we debrief it. And we say, what went wrong? What could have we done better? So the next time that it happens, we're more prepared. And that's what supervision truly is preparing you to be successful, putting you in a situation where you have the knowledge and the skills and the direction to be very competent and successful in the role that you've been given. That's what supervision is. It's not about tearing people down. It's not finding, things to critique. It's not finding you did this wrong, this wrong, this wrong. It's about, you know what, hey, let's just talk about it. Let's have a conversation. And that's truly what supervision truly is about. And I think we need to wrap our heads around it. The other thing is that we all have to be acceptive of constructive criticism. We will all do things wrong. We will all have things that we can do better. And we shouldn't get defensive. We shouldn't get oppositional. But you know what? Hey, this is what happened. And these are my weaknesses. This is what I seen I could have done better. Can you help me with this? Can you, lead me in the right direction? Can you provide me some feedback on those kinds of things? And being part of those debriefing situations and not just sitting back being a stoic participant who's pissed because you feel like you're being criticized. That's not making things better. That's making things defensive. And so we all have to be part of we all are part of of making it better. We can be part of the problem or we can be part of the solution. And that's what the whole situation is about. So there is a medical hierarchy when we think about it. So just, I don't know military, but there's a hierarchy in the military, right? There's a hierarchy in the medical field as well. And that hierarchy is the clinical director or the medical director, whichever that is, physicians, mid-levels, registered nurses, mastered prepared nurses, bachelor's prepared nurses, associate prepared nurses, LPNs, and then all unlicensed personnel. And so really there is a hierarchy, so when there's a code walking in, right? When somebody comes in and there's a code, the doctor assumes the supervisory role of the code, right? That's their hierarchy. They should do that, right? And that's just kind of how things are and kind of how things flow. But I think it's also important to remember that experience should play a role in that hierarchy. Just because you're a brand new nurse and you may have a bachelor's and I have an associate's, I bring a lot of years of experience to the table, and that needs to be respected, and that needs to be valued. So it's one of those things you have to work together. It's a working collaboration. Did you have something to say, Kobe?
Yeah. So is there anything that, as in medical delegation or task, is there anything that a AA registered nurse can't do that a BSN can't do or can't?
The only difference between an associate level nurse and a bachelor nurse is a bachelor's nurse is prepared in the supervisory role. The only difference. Okay. They'll have some public health background. A bachelor prepared nurse will have some public health background to them. And then they're prepared for the supervisory role or supervisory position. But legally, an RN is an RN across the board. If you look at scope of practice that's delegated by the state, an RN is an RN. Now, you can have some policy differences in each institution. There's a lot of institutions that you cannot be a director of nursing without a bachelor's. You can't take those supervisory level jobs. If you go to the big hospitals like, Rapid City, Sioux Falls, those kinds of places, you cannot be a charge nurse unless you have a bachelor's degree, just because of that supervisory preparation that takes place. Does that mean that a bachelor's level nurse is better prepared for that supervisory position? No, because I know a lot of BSNs I would not want treating me or my family. And I know a lot of associate level nurses I'd put my life in any day of the week. It is what it is. But we have to understand we work in a field based upon degrees. And so when you look at the hierarchy of things, those degrees are looked at. But like I said, there's individual differences, and I would hope that a bachelor's level nurse would take a step back if they had an associate level nurse there who knew what the hell they were doing. Because, like I said, I know associate level nurses I would lay my life in any day. That's just how things work. But we work in a field where degrees are important, and there is a level of hierarchy based upon the degrees that are given. Okay. So appropriate task, and I kind of divided these up a little bit. Oh, please stop.
Well, can I have that computer in the...
No, I'm using the computers. You need to go.
No, the other computer in the printing room.
No. You have a tablet. So I broke them down into licensed practical nurses and assistive personnel. So a licensed practical nurse can do ongoing assessments. Remember, they can't do the initial assessment, but they can do ongoing assessments. They can reinforce teaching. So you cannot do any discharge teaching or any initial teaching, but you can reinforce that teaching. They can perform tracheostomy care, so anybody who has a trach, you're licensed to do that. Suctioning, nasogastric feeding and nasogastric tube, those kinds of things. Enteral feeding, so feedings that go into the peg tubes or anything like that, you're licensed for all that. Inserting urinary catheters, administering, putting an IV in, and then administering IV antibiotics, with the exception of the first dose. The first dose has to be done by a registered nurse, just because there's a higher chance of anaphylaxis with the first dose. And that's why they say an RN needs to do it. Whatever. An RN's going to hang it and walk away. They're not going to sit there and watch it be infused, but the law is the law. Assisted personnel, they can do all ADLs like walking and bathing and grooming and all of those kinds of things. Toileting, ambulating, feeding, positioning, specimen collections, intake, output, and then vital signs. And behind vital signs, I would challenge you that they should only do vital signs for the stable patient. If it's an unstable patient, it truly probably should be done by an LPN. Okay? The right task and the right assignment. Who could do a nebulizer treatment?
LPN
No,
or
right.
med tech,
Who could do walking a patient?
CNA,
So you could delegate walking a patient, right? Using a bedpan.
LPN or CNA, doesn't whoever can do
But
it.
when we're talking about this, I want you to identify what you can delegate as an LPN. I want you to start practicing what you can delegate, okay? So vital signs for an unstable patient.
LPN.
LPN. Administering pain medications.
LPN.
LPN.
Reassessing a patient.
LPN.
Intake and output.
CNA.
CNA,
Yep. Enteral feedings.
LPN,
IV antibiotics, the second dose.
LPN,
LPN.
I'm doing a lecture right now. Okay. Delegation and supervision. I'm going to turn my light on. If you get old like me, you can't see as well. So it needs to be clear, concise communication. Okay? So if I want somebody to do vital signs, it needs to be, can you please do vital signs on room 42, bed 2? Clear, concise. Tell them what you want. You don't need to elaborate. You don't need to micromanage it. Let it go. Closed loop communication, which would be, you would say back to them, okay, you want me to do vital signs on that patient. Is there anything else you want me to do? You're closing that loop. You're recognizing that I heard what you say and I'm verbalizing it back to you. That's closed loop communication. Advise skills and roles. So if there's something that you need done. So let's say you have a patient who needs to be put in restraints. So you may need to provide education about how we do this, going and showing them and, getting out the monitoring sheet, the flow sheet to check that and those kinds of things. So that's advising the skills and the roles. Evaluation, going back and saying, if somebody brings you vital signs, this happens a lot, and it really is frustrating to me when they'll get vital signs and then they don't tell you about anything that's abnormal. So it would be like, you know what, hey, the vital signs you got on that patient, his pulse was like 110. In the future, could you notify me? That's tachycardia. And, so either they might be in pain or they might have an infection or those kinds of things. So if you could please notify me about that in the future, that would be really great. So providing that evaluation and that feedback. And then that constructive and positive feedback that we talked about before. So valuable that you do that. I always tell everybody, it's not what you say, it's how you say it. You can tell somebody what to do, but it's how you say it.
Right.
I've been told several times that I have the ability to tell people off with a smile on my face. So see, it's like I can tell you anything what you want, but it's how I portray it and how I carry it. So be mindful about that. Nobody wants to be treated disrespectfully. Nobody should be treated, like they're an invaluable member of the team. We all work together and we all do what's best for that patient. The only way a patient wins is when we all work together. And so providing that conducive work environment is so important. Okay? You can tell anybody anything you want, but it's how you tell them. Please and thank you go a long way. Or you know what? I really appreciated that you did that. You took them outside for that walk. I cannot believe how happy you made them. I really appreciate that you took the extra mile for that. Giving those kudos when those kudos are warranted, because we have tough jobs. We do a lot of strenuous, not just physically, but emotionally and mentally job, all the time. So making sure that the only people who take care of each other is ourselves. And so we need to make sure that we're doing that. So that's what I have for delegation and for supervision. What I want you guys to go back and to really look at is if you look in your ATI book, there's a section about delegation and supervision, and it shows you tablets. It shows you tables of what every position can do. I'm going to find it so I can not remember my pages differ than yours. Chapter 6 I have.
Okay.
But there is a section that talks about things that LPNs can do and things that APs can do. Okay? And then there's different examples of what is the wrong delegation. Okay, so delegating an AP to administer nebulizer treatment to a client who has pneumonia, that's absolutely inappropriate, right? Inappropriate. Delegating an LPN to give an IV push medication, inappropriate. They can't do it. Legally, they can't do it. You can't give IV Lasix. You can't give IV morphine or any of those kinds of things. You can give all the oral medications, but an IV push medication you cannot give as an LPN. So it's a poor delegation. It's wrong. You can't do those things. So making a determination or whose responsibility, if it's you and assistive personnel in a room and you find a patient who has snoring respirations and they're hard to arouse and they were recently given morphine, who reports that?
CNA.
The CNA or the LPN? Whose responsibility is to do that?
That's
Depends.
an ongoing assessment, isn't it?
It's reassessing a patient. Whose responsibility? If there's an LPN and a UA and an unlicensed assistant there, that's your responsibility as the LPN. That's an ongoing assessment. They were just given medication, you're reassessing it. That's your responsibility at that point in time.
I don't know this woman in the trash. Can you get those Garderos for me on the stove?
So can an LPN give morphine orally? Like
Absolutely. Absolutely.
Okay.
Yep, an LPN can give all oral medications. There is not an oral medication that an LPN cannot give. But you cannot give IV push medications. So like if I needed to give IV morphine, I would have to do that as the RN. But let's say I just needed to hang normal saline at 100 mils per hour. As an LPN, you can hang that. But now what if I had what if I had normal saline with 40 milliequivalents of potassium? Could you give that? No, because it's more than 20 milliequivalents of potassium. It has to be done by an RN. What if it was the first dose of Levaquin IV? Can you give that? Could you give the second dose? Absolutely. What about a patient who needed to be transfused a unit of packed red blood cells? Can you do that? No, but a nurse can do that. An RN can do that. Absolutely. So just knowing what you can and can't do, working within that scope of practice is so important. And so when we talk about delegation, that's going to be a lot of the things that we talk about. There will be questions about which patient is a priority. Who takes the priority? So let's say you were assigned a patient who was ready for discharge. You were assigned a patient who is there, status post-total knee with rehabilitative services. You were taking care of a patient who was febrile, who was intermittently febrile with pyelonephritis. Or you were taking care of a patient who was status post surgical, who just came off a PACU. Which is your priority?
Someone who just came out from PACU?
Absolutely. You have to think about which patient is the most critical, which patient could go bad first. The other ones are pretty stable. Now, the intermittent fevers, it kind of makes you question that, right? But they are more stable than the person who just came off the surgical floor, who just came out of PACU, right? Because that person still has a lot of meds on board, right? So that patient is your priority. Now, but given different circumstances, that patient with pyelonephritis could have been your priority patient. Had it been, a patient ready for discharge, a patient who was there, who came in for, IV antibiotics, then it changes. Then, yeah, that patient is your most critical patient at that point in time. And so you'll be giving questions like that, okay? Now, we've talked about it before, to always remember when you're looking at the most critical thing, you go back to ABCs: airway, breathing, circulation. So when you're talking about those patients, trying to figure out which patient is your priority, if you have an airway patient, they're your priority. You have a little kid who comes in with epiglottitis, he's your priority because you could lose that airway in a matter of seconds. If you have a patient who has snoring respirations and is hard to arouse, that's a breathing complication there. So that patient may take priority. Or you have a patient who has sinus tach at 140. Well, if you don't have an airway or a breathing problem, the sinus tach could be your highest delegation, your highest, intervention. So it just really depends. So make sure that you're always going back to your ABCs and you're going back and asking your question, which patient could go bad on me the fastest? And that's your priority patient, okay? Those are the patients who should be looked at and assessed first. So, question for you. Let's say you came on and you were working the day shift, and could you go and assess that patient for the day?
Yeah, if it's already been.
Yeah, absolutely. If they've already been seen and assessed by an RN, at one point in time, the initial assessment has to be done by an RN. After that, an LPN can assess them after that. So, though, if those questions come up, absolutely you can assess that patient and you can take care of that patient. You just can't do the initial. So, somebody who's coming on as a new admission, can you do that patient? No, because it's a new assessment. Somebody who's coming back from the PACU, could you take that patient?
Yeah.
Absolutely. They've been assessed by a nurse. The nurse is discharging them from PACU, from postoperative care. So they're being discharged by an RN to your floor. So it's a step down status. So of course you can see that patient because they've been assessed by an RN. So somebody who is post-surgical and they're coming back to a rehabilitative floor, can you assess them? Absolutely, because they've been seen by an RN before, right? It's a step-down facility. And so now you can see them and you can assess them, okay? Trying to think.
So if they're getting discharged from one place to another, you can assess them.
As long as they're in the same facility. But if I discharge them from my hospital and I send them to a nursing home, you can't assess them because nobody at your facility has assessed that patient first. But let's say you worked at the hospital with me and I was sending this patient to a step-down program, to a rehabilitative program, then you can assess them because a nurse in your facility has done the assessment on that patient.
Okay.
Okay. All right. Any questions that you guys have for me? What I want you guys to do is when we get done with this, I want you to take about 10 minutes and go back and I want you to read this 7-page chapter in ATI. because it's so important that you understand this delegation and supervision. Because it is really hammered hard when you get to NCLEX. And there will be questions from here throughout every test that you have that are delegation driven, just to prepare you for this. Because this is something that's an ongoing issue, and I want to make sure that you understand it and you understand it well. There's not a lot of information to it, but it's very important information. So I want you to take about 10 minutes, go back and reread these chapters, and just make sure you understand what those scopes of practices are. What can you delegate and what can't you delegate? And understanding the difference between delegation and supervision, because there is a big difference there in understanding that terminology. Okay? Any other questions for me? No? All right. That is all I got, okay? Now,
All right.
on Wednesday, we'll go over to contemporary cares and interventions that are out there. And then we'll go over that that question, those questions that I sent out for you guys to kind of practice. We'll go over those again on Wednesday then and see where we're at with that. Okay?
Okay.
All right. Now, next week we go over integumentary. And I'm going to go a little bit more in depth because I'm a person, if we're going to talk about skin and infection, we're going to talk about all of it. We're just not going to talk about part of it because it doesn't make sense to me to break this up in choppy little pieces. So when we do it all. And we're going to talk about everything. So we'll talk about the chain, the chain of infection and all of those kinds. We'll discuss all of that process. But we're also going to talk about some pathology that comes in because I can't talk about infections and then not talk to you about what types of infections can happen. To me, that doesn't make sense. So you'll get everything and it will be comprehensive, which I think is probably a little bit more than what is set out for us at this point in time, but then we won't have to revisit it later because we've talked about it, we've discussed it, we've gone over all of it. Okay, and I need to go through that that PowerPoint, and I will get that fine-tuned and get that out to you guys here by the end of the week. Okay, all right.
Okay.
Otherwise, we will see you on Wednesday, and we'll talk about contemporary medicine, and then we'll go over those review questions.
Okay.
All right. I might have to go drink if my Vikings are getting beat. So chance that can happen. I almost had to drink yesterday when Green Bay won because I was so mad about it. I'm like, sucker.
I delegate to you to go
I cheer
drink.
for any team that plays Green Bay. They're my team for that day. It's just the way it goes. And they won. All right. You guys have a good night.
Right,
See ya.
see ya.